Hi, this is Jennifer Klimek Yingling. Welcome to 50 Shades of Gray, Understanding Chest X-Rays. If you like what you see today, please like us and share our resources. You can find us on Facebook under the APRN Central Study Group, Instagram, Twitter, and at www.aprncentral.com. And there'll be more topics to come in the future. So now that I got your attention with our really catchy title, 50 Shades of Gray, I'd really like to get down and dirty and talk to you about chest x-rays. I feel like this is a topic that NPs really sometimes struggle with, nurses in general struggle with, and hopefully today we'll be able to give you a better understanding of what you're seeing and some of the reports that you're getting back from the radiology groups. Some radiology principles to keep in mind is always, number one, when you are deciding whether or not to order a diagnostic, whether it be a lab test, an x-ray, a CAT scan, always ask yourself, is this test necessary? You really don't want to just order tests to order tests. You want to really let your physical exam drive your suspicion and your differential diagnosis. Some of the 10 commandments that they talk about, the radiographic commandments, you'll hear the radiologists talk about this, and they talk about one view is two view. This is especially true when you're thinking about skeletal x-rays, because one view may not tell the whole story. And just like that, with the skeletal surveys, what you might think about with the chest x-rays is just a pure one view of the chest x-ray may not give you the whole story either. You may need to add a lateral view if your patient is well enough to be able to get that done. Radiologists will often, they'll even go to the extreme of saying one view is no view. And they really just mean the same, that one view may not tell the whole story. One of the things you may want to do when you're looking at your chest x-rays is to look at some previous films. This may help you look at any disease progression, any improvement or worsening of conditions, and really will give you a frame to kind of look at what you're looking at, the most current exam that you've ordered. You really need to think about cumulative radiation exposure in your patients. I think that we've kind of swung to the other end where we're not, just knee-jerk ordering diagnostics, but it's important to keep that in mind. We do know that large amounts of radiation are not good for our patients. We know that it may increase some carcinomas. So you always want to think about risk versus benefit. If you can, now I'm talking about abdominal type of radiology, you really, if you can, start with an ultrasound because there's no radiation involved at all. You want to avoid radiation in your young patients. Especially if you are doing abdominal series, you think about that, you're going to be x-raying right over the reproductive organs. And we know this is bad business. So try to avoid radiation in your young patient. Try to also avoid redundant or repeat exams. Patients sometimes will be seen at multiple facilities, and sometimes in one day will have received 2 chest x-rays. So if you can, get that film from the other facility, get the report, let that guide you versus just snapping another one. I know sometimes you're tempted to do that because we all want it, have it your way, drive through, quick, and but you take the time, get the release signed and get that x-ray or the report sent over to you. It's important to think about too, you want to order the right test at the right time. If you have a patient that you're worried about a pneumonia, uncomplicated, low comorbidities, it wouldn't be the best test to order a CAT scan of the chest, right, to start with. You want to start with the right test. So a chest x-ray would be the better option to screen for your pneumonia if that's what you're suspect of. And so you want to make sure, and I'm thinking about the patients that I will see in urgent care or in the ER. I go in the room, they've had some right upper quadrant pain. Today their lab works off a little bit. I'm suspect of a cholecystitis, and they have eaten a bag full of fast food between the time they had their lab drawn and when I come back in the room to discuss it. Now, I'll know that that isn't going to be able to be a stat exam because you can't do a gallbladder ultrasound if they haven't had a period of fasting. So just keep that in mind. There are some rules for some of the diagnostics that we're going to order. If you have the ability to, and the insurance is going to allow you to, you may jump to an MRI versus a CAT scan if that's the best exam. And I'm thinking about some of our neurotype symptoms because, you think about the MRI and there's less radiation uptake as compared to the CAT scan. So the right test, the right time, you want to make sure you're using your criteria and guidelines. And, the biggest pearl that I can give you is know what you don't know. It's fine. You're going to need to make some friends in the radiology department. If you're working inpatient, the techs can kind of help you, geez, I'm going to look at this. Sometimes, for example, especially when you look at the electronic charting systems where you have a menu that you have to choose from, and you may not be able to, choose exactly what you want. I think about things like if I'm looking for mastoids, I'll call over to CAT scan. Okay, how do you want me to order that? And they'll generally kind of guide me through how I can get it through the electronic chart. The other thing I do a lot, and I've always made a point of being really collegial with the radiologist because they really are there to help you. They don't always get a lot of calls over there. They're reading x-rays and they really are there to help. So those are one of those, who are the friends in your neighborhood? You need to make friends with your radiologist because they are there to help. So just a couple pearls and some radiology principles. So the radiodensity scale. Basically you need to think about a chest x-ray as a film. It's a black and white film, and it's used to produce images of the heart, the lungs, the vessels, the airways, the bones of the chest and the spine. And I'm talking now, we're going to move right into our chest x-rays. You may also detect fluid on the chest x-ray, but one of the things that you need to understand is the radiodensity scale. And when I chose the title of this mini lecture, I thought about 50 Shades of Gray because you're going to be looking at all different shades of gray, and it's going to kind of give you a clue at what you're looking at. So it does make a difference. So the 50 shades, the densities, basically different tissues of the body absorb X-ray at different extents because of the how thick something is, or is it man-made. So the first thing you're going to see when you look at your x-ray is that black, and when you see the black you think about air. Okay, usually the second thing you'll see is a dark gray, and that's usually tissue or maybe even water. Then somewhere in the middle you're going to see like a light gray, and this usually is body fat or soft tissues. And then you'll see something that's kind of like an off-white. And as we go through and we're looking at these different x-rays, you're going to see what I mean, off-white versus bright white. Off-white is usually bones, okay? When you see something that's super radio opaque, white, bright white, it's usually metal. It's usually something man-made. You may see it with some of our veterans who have a retained bullet, gunshot wound victims. Sometimes if you have a foreign body, if it's metal-based, some of the old glass, if you have somebody who is, broke their hand on some of the older glass that has lead in it, you may see the glass and it may appear to be radio opaque on the x-ray. So just keep that in mind. The other thing is you want to make sure that your patients are undressed, especially females, because and we'll talk a little bit later about diaphragm and air under the diaphragm, but you want to make sure that especially a woman who maybe is wearing a metal underwire bra, that'll show up on that x-ray. So they need to, have everything off on the top when this is done. So that's just a little talking about the different densities. So the next thing we're going to talk about is penetration. And so we talked about, some of the densities, some of the different shades of gray, and, the technique that the x-ray technician uses will sometimes influence the way that the protons will travel through the patient. So that exposure. So if it's underexposed or overexposed, it's going to make a difference on how the x-ray looks. And this slide really is a great example of that, because you can see on your right, this is the same patient, how light it looks. And it looks almost like this patient might have a pneumonia. And you look to the slide over to your left and how dark and black that x-ray looks. So, you could see this sometimes too. If the patient has a large body habitus, the exam may be very limited, especially in our bariatric patients, because you're shooting through all that fat, and the protons can't get through, so you're not going to get a good picture. So just keep that in mind. Your ideal radiograph is when you can barely see the thoracic spine through the cardiac silhouette, okay? And sometimes if you look at the shoulders, that'll give you like an estimate of relative degree of penetration to the film. So you can see the film on your right, you can't even see the bones of the shoulder. So that's really over-penetrated. So what are some indications for ordering a chest x-ray? Has your patient had a chronic cough greater than 8 weeks? Are you looking for some kind of pathology? Have they had some sort of trauma? Have they fallen on ice? I live in the Northeast. We have a lot of ice, and it stays a long time. Comes early and leaves late. Did they fall on a wet floor? Are they complaining of rib pain? Were they in a car accident? Are they complaining of chest pain of a different etiology? Is it cardiac? Is it something with the lungs? Are you working up a shortness of breath? Are you looking at, is there asthma, COPD? Is there CHF? Is there a lung carcinoma? Do they have a pneumothorax? You think about your tall, very slender patients, especially young men who are very athletic. They are at high risk for a pneumo. They will come in with acute onset of shortness of breath while they were maybe playing soccer, baseball, whatever. And we also often look for lung-related infections, and two of the big ones are tuberculosis and pneumonia. And we'll talk a little bit about where you're going to see those on your x-rays as well. So it's good to understand the basic views that you can order to get a chest x-ray. And this can be confusing, especially when you first start practicing. It used to be a lot easier when we used to handwrite our orders, I suppose, because you could just write what you wanted. It's a little bit different now. So when you go into your electronic charts and you are putting your orders in, you may have all the different options, a whole menu of chest x-rays. So you're going to see the posterior anterior, the PA view. You're going to see the anterior posterior, which is an AP view. You're going to have a lateral view, and sometimes you may order an oblique. Excuse me. So your posterior anterior, your PA view. So take a look at this slide. This is the position your patient is going to be in as they do the chest x-ray. So when you're looking at this is a patient that is generally standing, and the patient is standing facing the film. Okay, so if you think about their position, their heart in this view is closest to the film. And that being said, this means that there's no artificial increase in the size, and so, because you're looking for the true size of the heart and the different structures that you're going to be assessing. This is considered the best way to do it, but you're going to be taking care of patients who may not be able to stand. The next view we'll talk about is the anterior posterior AP view. Okay, this is the chest x-ray that we order for our ICU patients, ER patients, that are getting done right in the bed. These are really sick patients generally, and this view will cause a magnification of the heart vessels. Okay, so think about it and look at how this patient is positioned. Okay, their heart is farther away from that x-ray film. Okay, so this is your portable chest x-ray usually. Okay, the lateral view. Why would we do a lateral view? We're going to go back to those, radiology 10 commandments. And this is so we can get a side view. This gives us a more three-dimensional look at the lung and the cardiac structures. And it allows you to be able to localize something that might be hiding behind the heart. Sometimes you'll have a retrocardiac infiltrate that you can pick up, and you'll see it only on the lateral view. Okay, and then there's the oblique view, and this is an alternate way to detect a pneumothorax, and this is used because it's a little bit easier to get some of those subtle pneumothoraxes. You may it'll allow you to evaluate any abnormal cardiac shadows or your mediastinal structures as well. Okay, this is a picture of the shadow puppet, and this is just to kind of knock that concept home to you. So when you're thinking about what you want to order, you think about, anterior, posterior AP view, or are you going to do the PA view? And you think about where they, think about that radiology, those proton beams going towards your patient. And as the shadows grow bigger, as an object moves closer to the light, okay, they appear smaller as they move away. So you think about when you're a little kid and you were, maybe making a crazy rabbit or a monster, and you wanted to get bigger, you would move it closer to the object. So just keep that in mind. That might be an easier way for you to kind of remember how the structures are kind of skewed depending on what view that you choose. Okay, here is the same patient, and it is, I like this slide because it'll allow you to kind of note the magnification in the AP view. Okay, just another way of looking at it. So when you're ordering your exam, you want to make sure you order the right exam, the best exam, because if you look at this one, your AP view, it almost appears that the patient has a cardiomegaly. But as you see in the PA view, that is not the case. Actually, I'm going to go back because I guess I have a little more to talk about. So just to kind of circle back and talk about some of the differences between the AP and the PA view. So your posterior view, these patients have to be able to stand. You're going to notice if you look at them side by side that the ribs appear to be more horizontal. So if you look at the ribs from on the PA that's on the left hand side of your screen versus the right, you can see in the AP view the ribs almost look like they're curving upward. Okay, they're angled upward. So you go back, you're going to also, with the PA, the heart is closer to the film. It's more of a realistic estimate of what's going on, and this is the best way to demonstrate the actual cardiac size with minimal magnification as compared to the AP view. And this slide really hits that point home. With the AP view, just one other thing, you can see that the heart is further away from the film, so it does appear larger, and you really are not able to estimate the heart size. Okay, so right test at the right time. All right, inspiration and expiration. You may see on your chest x-ray reports, they'll say poor expiratory effort. Okay, poor inspiratory effort. They cannot exclude. You're going to see that on every film. But basically, you want your patients to take a nice deep breath and hold. Okay, this is generally what you want your patients to do. You may order expiratory films if you're looking for a pneumothorax, and the reason why you're going to have your patient take a big breath, hold, blow it all the way out, and hold, and you're going to look in this film for any pleural air accent or any atelectasis or air trapping. Okay, so for your pneumos. All right, now that we've discussed the different techniques and the different views that you can order, Let's talk about some of the other things that we need to pay attention to. So one of the things that's really important is you need to make sure that you're looking at the right patient. You're going to be really disappointed in yourself or frustrated. I know you're going along your day, it's a busy day, and you are looking at a chest x-ray and you see this abnormal finding, and you're thinking to yourself, I just examined this patient, the lungs were clear, I didn't really see anything, and then you realize that this is the wrong patient. So make sure you're checking it's the right patient. You want to look at the date that the exam was done. This is really important if you're comparing prior exams. You don't want to be looking at a prior exam that may have looked worse than today's exam that shows an improvement. You want to check for position markers, right versus left, upright. And I can just share a story with you. This is years ago. We had a baby come in with mild respiratory issues, and I ordered a PA view, and I got the chest x-ray back, and I'm thinking, oh my gosh, they put the wrong markers on because everything was flip-flopped. And so I called over to x-ray. I'm like, did you guys, maybe have the markers flip-flopped? And the tech was, Johnny on the spot, good tech. Nope, Jen, I really, it was on the right spot. Well, this baby ended up having dextrocardia, and they were a young infant. They ended up getting transferred to one of the big university centers. So just another reason I'm just trying to hit that home, that make sure that the markers are on right, that the exam was done in the proper manner. X-ray techs are really generally super good about that, but you know what? Never say never. We just need to be vigilant, all of us, that we're, doing everything we possibly can to do the best job for our patients. So other things that you might want to check too is the type of film that was ordered. When you first get going, you may have things pop up, or you click on your exam and you're like, geez, I don't know how to read this. It may be a CT Pulmonary Angiogram, it may be an MRI. So pay attention. Is it a CT? Is it a CAT scan? Is it an MRI? What are you looking at? Think about your patient's position. Are they supine, upright, lateral? Are they in a decubitus position? And then, you want to think about the technical quality of the exam. We talked a little bit about the underpenetration, overpenetration, and how they can really skew your findings. So, if there is a lot of motion or the film is overexposed, you may not see some of those subtle things like a pneumo when you're looking at the film. Sometimes with kids, it can be tough too, especially our toddlers. Terrible 2s, treacherous 3s, they are little wiggle worms, and sometimes it can be very difficult to get a good picture of what's going on. So your initial survey, you want to look at your x-ray, you want to, kind of look at the general body shape, the size, the symmetry. Is it a male versus female? Is it an infant, child, young adult, or an elderly person? You want to survey for foreign objects, tubes, IV lines, EKG leads. You may see surgical drains, prosthesis, as well as non-medical objects, bullets, shrapnel, glass, the bras again. You don't want to miss something because something is in the way. And I can share another quick story. I often will x-ray dog bites, and especially if it's a really significant injury. And I had this fella, and I x-rayed him, and I'm like, wow, it looks like he's got a fracture. And I go back in afterwards. I mean, it's pretty tender, and I'm pushing on the bone, and does it hurt? And he's like, not really. Come to find out, it was actually one of the dog's teeth broke off and was in that wound. So that was pretty interesting. So you want to look and see if there are any foreign bodies. So you want to, when you're going through and you're looking at your chest x-rays, you want to kind of follow some kind of system. And the easiest way to remember what you have to look at is follow the A, B, C through H pattern. and when you look at each x-ray. So you're going to look at the airway first. Second, you're going to look at the bones. Then you're going to look at the cardiac silhouette. D for the diaphragm, effusions, fields, your lung fields, G for your gastric bubble, and H for hardware. And we're going to go through this throughout the lecture so you can kind of put all these pieces together and understand what you're supposed to do. Okay, so when you are looking at the chest x-ray, the first thing you're going to look for is your airway. And this is a nice picture for you to kind of see what you're supposed to be looking at. So the first thing you're going to look at, you're going to locate the trachea, and you're going to follow it down and look at the right and the left bronchus. Okay, you're going to look at the film. Is it midline, or is it deviated one side or another? This may give you a clue that if something's going on as well, and kind of lead you to the problem. If your patient has an effusion, the fluid is going to push the trachea in the opposite direction. Okay, if your patient has a pneumothorax, you're going to see that their trachea is pulled to the other side. Okay, you can also see, is the ET tube in place? We know that if you're going to be looking at proper placement, you want the ET tube about 3 to 5 centimeters from the carina, and then the carina is where the trachea branches. Okay. All right. So next you're going to be looking at the bones. Okay. You're going to look at your clavicles. You know, do they have a fracture? Is this a trauma? Because you don't want to miss the forest through the trees. You know, you're worried about a rib fracture, but you missed the clavicle fracture. You know, make sure your physical exam is driving. Sometimes I'm looking at the patient, I order a chest x-ray, I may go back and look at the patient again, kind of palpate things, percuss things to see if I can elicit pain over an area of that I find an abnormality. So you're going to find that first rib right above the clavicles, posterior. Okay, if you're looking at your x-rays, once again, you know, you want to know, is it a PA or an AP? You know, the ribs, if you're looking at a PA view, which is our most common view that you're going to want to order, the ribs are going to really look horizontal. They look horizontal. More horizontal are going to be your posterior ribs. Okay, the ribs that you see that are kind of pointy, are more vertical, those are your anterior ribs. Okay, you're going to look at your spinous process as you're going down. Is the spine aligned? Do you see a compression fracture? You're going to look at the bones in general. Does the patient have osteoporosis? You know, some of our elderly patients, you're going to look at their bones and you're going to be like, I don't even know. They look like their bones are transparent. They're so they're so osteoporotic. You may see lytic lesions. These look like little holes in the bone. You know, somebody that has metastatic disease, you may see that. So that's another thing that you're going to be looking at. And then you're going to count the ribs. Okay, so you go through and you count your ribs, and in a normal chest x-ray, normal lung expansion, you're going to be able to count 8 to 10 ribs. Okay, if you can count more than 10 ribs, you need to think about hyperinflation. Less than 8 ribs, this is poor lung expansion. All right, and you should be able to see the diaphragm about the level of the 8th and 10th posterior rib, or the 5th or 6th anterior rib on good inspiration. Okay, so just keep that in mind. All right, rotation. When I talk about rotation, this means that the patient is centered. Okay, rotation can distort the mediastinal anatomy and make assessments of the cardiac chambers and the hilar structures especially difficult. So you want to pay attention to this. You know, the chest wall tissue also, if the patient's rotated, can contribute to increased density over the lower lobe fields, so it can look like they have infiltrator effusion. So that's another reason that you want to, you know, pay attention. Are they rotated or not? So how you look at that, the rotation of the radiograph is assessed by judging the position of the clavicle heads in the thoracic spinous process. So you can see the marker on this chest x-ray. You can see the markers pointing at the heads of the clavicular heads, as well as centered right in that spinous process. And you can see that the distance between the clavicular heads is equidistance, okay? So you want to identify rotation, you're going to look at those clavicular heads, and they should be equidistant from the spinous process. Okay, same patient. Okay, look at the rotation on the film on the left. And you look at the clavicular, you know, are they equidistant? Yes, the patient's rotated, but if you look at the x-ray on the right, you can definitely see how rotated the patient is, and you can see how different the x-ray looks. So this is just an example to show you what rotation can do to your x-ray film and how different it can look. All right, this patient, and the markers on there, and you're going to look at the clavicular heads, and you can tell that they aren't equidistant. It's not centered. Okay, so just another example, because I think with chest x-rays, the more you see, this is more something you really need to look at to get a good understanding. So that's why I'm using so many pictures, and that's why I ended up doing this as a video versus live, because I don't know if the live feed was the x-ray pictures would come out as well. Here's another picture of rotation, and this one really hits home the fact with the clavicular heads. I mean, this almost looks like they have a dislocation. They are so rotated, almost on their side. Okay. All right. So now we're going to look at the ribs. Okay. So we've looked at the clavicles. We've looked at the vertebrae. Now we're going to count the ribs. All right, once again, we're going to look at this x-ray. The clavicles appear that they're straight. Well, they're slightly rotated maybe, but not awfully. And we're going to count the ribs, okay? And here we go. You're going to start from the top, right above the clavicle. You're going to find that first rib. It hides right posterior to it, okay? If you look on the left side of the screen, you've got the 1, 2, 3 in black. Okay, and you can find right behind that clavicle is the beginning of the first rib. Okay, and you're counting from the back to the front, because remember, your patient is facing the film. Okay, so when you count your ribs, 8 to 10 again is normal lung expansion. With this patient, we can see that we can easily see 9 ribs, so it's normal lung expansion. We go back to and think about it, 10 plus is hyperinflation, less than 8 is poor lung expansion. Okay, let's look at this x-ray. I'm going to give you a minute. Take a stab at counting these ribs. Okay, you should be able to count 10 ribs. Okay, so it's a normal lung expansion in this patient. Okay, so this is an example of good inspiration, rotation, angulation, orientation, and penetration. Perfect. Okay, the other thing you may see, and when you're looking at your chest x-rays, is you have to remember and go back to anatomy. You have your minor fissures and your major fissures. Okay, and what can happen with the fissures, sometimes there can get a little bit of fluid in there, and you'll end up seeing these lines on the chest x-rays. So just be aware where they are, because you may see some fluid in here. And I'm going to give you an example here. You can see the right minor fissure here. There is some fluid in it. With this x-ray, you can see this is what a mitral valve replacement looks like. You can see that mitral valve looks like a nice little circle. And you can also see sternotomy wires on this x-ray as well. Okay, so the next thing you're going to want to take a peek at is the cardiac border. Okay, so your cardiac silhouette should not exceed greater than 1/2 of the total width of the chest. Keep in mind, in your pediatric patients, the hearts are about half the size of the chest. Okay, and remember, this is only an estimate. So about 2/3 of the heart should be to the right and 2/3 to the left. I'm sorry, 1/3 of the heart should be to the right and 2/3 to the left. Okay, if it's greater, some of the things you might consider is cardiomegaly, CHF, pericardial effusion, and your cardiomyopathy. All right, what do you think's going on with this patient? Would you say that the cardiac silhouette is greater than half the width of the chest? Would you say that 1/3 of the heart is to the right and 2/3 to the left? Okay, this is a patient with cardiomyopathy. So you have a big boggy heart. Okay, moving on to the mediastinal anatomy. This is important for you to pay attention to as well, because we know that a widened mediastinum can be bad business and indicate a AAA. So some of the things you're going to be looking at, and I like this slide because it kind of shows you that right atrium. It shows you your diaphragms. You see that aortic notch. Okay, so take a look. All right, so if you look at this patient, this is a patient with a normal width of the mediastinum. Okay, see, it's not terribly wide. I'm going to show you what I mean with a widened mediastinum at the next slide. Okay, you worry about a AAA. Okay, here's another one. This is a widened mediastinum with a cardiomegaly. And you can definitely say that with the principles that we talked about, that 2/3 of the heart is on the left and only 1/3 on the right. That's blowing that one. Is it more than half of the diameter of the chest? I would say yes. Okay, so another big boggy heart. All right, let's talk a little bit about the diaphragms. Okay, so what you're going to see is when you're looking at the structures, you're going to take a look at the diaphragm, and you're going to notice that the left diaphragm is lower than the right diaphragm, and that's a normal thing. Some people's are more equidistant, but if it's greater than 3 centimeters, you need to think about what's going on with this patient. And this is an example of a hemidiaphragm. Okay, this is can be caused by if the patient has any damage done to the phrenic nerve. This can happen if the phrenic nerve is damaged due to lung cancer. So just so you keep in mind, there's something else you would note. Okay, and why we're looking at the diaphragms, air under the diaphragm is, indicates, if we see a pneumoperitoneum, is free air. Okay, we get free air if there's a peptic ulcer perforation, if there's a bowel perforation, if there's a trauma. You also will see it in some patients that have had belly surgeries, and that's the one you're not worried about as much as the patient who comes in with some shortness of breath, and you see the air under the diaphragm. And it's funny, the story about this, I remember we were standing at the view box, and I put the x-ray up, and I was doing whatever, and the nurse comes next to me and says, "Oh, they must not have taken their bra off." And I was like, "No, the bra is off, and I'm really worried about free air." And that patient ended up going to the OR. So that's another reason you got to undress your patients. They don't always like it, but what are you going to do? All right, so when you're looking at the chest x-ray, you're going to be looking for effusions, you're going to be looking at the lung fields, and you want to kind of have a systematic way that you're looking at them. So you're going to look on the chest x-ray on your left. You're going to look at the shape of the lungs. You're going to look at the pleura. You're going to look at the costophrenic angles. Okay, they're nice and they're sharp. They're pointy. That's exactly how you want to see them. You're going to look at the pleura. You shouldn't be able to see anything. The pleura is usually invisible. You're not going to see anything, but you may see pleural thickening for whatever reason. In your patients with asbestosis, you may see particulates from the asbestos in there. And you're going to look at the shape. Do they look more like tombstones rather than angel wings? Because that tells us as somebody who's a long time smoker, somebody who has COPD. So take a look at the shape. Moving on to the picture on the right, it kind of indicates how you're going to go through from top to bottom, side to side, side to side, right down all the lung fields. Okay, you're gonna note your lung markings in a systematic fashion. Okay, so this is how you're going to be looking at it. All right, you're going to look at those costophrenic angles, like we talked about. The margins should be nice and sharp. This patient does have nice and sharp costophrenic angles. This patient, not so much. Okay, and you could see in this picture that that you can't see those angles, and that's where a little tiny effusion can hang out. There could be an infiltrate in there. In this picture too, you can see that there's a loss of the right cardiac border. Okay, anytime you lose the right cardiac border, can't see it, you need to think about a right middle lobe pneumonia. If you have any obscuration of the cardiac border on that right side, right middle lobe pneumonia. Okay. All right. Back to the sky. So they also call this blunting. The loss of the costophrenic angles. This can be a sign of a pleural effusion. It can be caused by some scarring. It can also be atelectasis. Okay. All right, when you first get done and you're out there and you're looking at the chest x-ray, you're going to see these structures to the left and the right of the heart. And this is the hilum. This is normal structures in the lungs. This is a normal finding. You don't get excited about that, okay? All right, next you're going to look at the lateral x-ray. Okay, you're going to do the same thing. You're going to look at the shape of the lungs, at the pleura. You're going to look at those costophrenic angles, nice and sharp. And then you're going to start at the top and you're going to go back and forth through all of the lung field. And you're going to look at the markings. You're going to look for any abnormalities and see if you can see anything. Okay. When you look at that lateral chest x-ray, there's some things you can see. You can see the sternum, the scapula, the trachea, the ribs, the vertebrae, and you can see in the lateral x-ray where you can see a retrocardiac, not in this one, but this is how you would look behind the heart to see if there's anything going on, a little infiltrate that's hiding behind there. You're going to see in this picture, you can see the diaphragm. You're going to see the right diaphragm that's higher than the left diaphragm. We know the left diaphragm will dip down a little bit. So that's what you're looking at in this picture. Okay, so a question for you. Where would you see TB versus pneumonia in the chest x-ray? Okay, this comes up a lot in the board preps, but it's just something you need to know when you're looking at your chest x-rays so you can kind of refine your differential diagnosis. So you're doing your exam, you're taking a look, okay? So keep in mind, not always, but most commonly, you're going to see TB in the upper lobes. And the lower lobes, you're going to see the pneumonia more commonly. Okay, this is another picture of the what you're looking at when you're looking at your chest x-ray. Okay, where is the left upper lobe, where's the right lower lobe, right middle lobe, the lingula. And I think you're going to like the next set of pictures because it really delineates where these areas are when you're looking at the x-rays real time. Okay, so this is where you would see an abnormality in the right upper lobe on your PA and lateral x-rays, okay? So take a look where that is. I'm going to go a little bit slower so you can kind of digest these pictures, okay? This is a right upper lobe. That's where you would see an abnormality. This is a picture of a right upper lobe pneumonia. Here's another picture of a right upper lobe pneumonia. So the right middle lobe, we talked about this. This should be one of the first places you're going to start picking up your infiltrates, because you're going to look at that right cardiac border. If it is skewed, if it is obscured, I want you to think consolidation. Think about your right middle lobe pneumonia. And we know with our young people, this is the spot that you're going to hear it. You want to make sure you're really listening in that axillary area when you're doing your lung assessment, okay? Because that may be the only spot that you're able to hear anything. All right, so right middle lobe. And we're going to go back to that slide we looked at before and look at that cardiac border. You've got a loss of the cardiac border. You can see the consolidation. Here's another picture of a right middle lobe pneumonia. Okay. Here's a right lower lobe. Okay. Here's a picture of a right lower lobe. You can see that it doesn't look great, but you can kind of see the right cardiac border there. All right, your left lower lobe. Here's a picture of a left lower lobe. So left upper lobe with the lingula. Okay, these are the areas you're looking at in your PA and lateral. Okay, that's just the lingula, the area you'd see it. Okay, that's your left upper lobe. All right, there's your left upper lobe pneumonia. Okay, so we've gotten all the way to G. So we're going to ask, where is the gastric bubble seen? You're going to see it below the left diaphragm. You may also look under this individual's right hemidiaphragm, okay? I want you to take a peek over there on the right side. And I want you to look at the color of the lung tissue. Okay, right below that right hemidiaphragm, you're going to see a medium shade of gray, right? All right, this is the liver. Okay, so it's more of a solid organ as compared to the lung. So that's what I'm talking about, these 50 shades of gray. You're going to have to look through and look closer at some of these subtle changes on here. You can see in the gastric bubble that there's fluid in the stomach. Okay, you see that fluid line. Okay, I want you to look at this x-ray. What do you see? We're at H. Thinking about your hardware, you can see a couple cardiac monitor lines. You can see sternotomy ties with this patient. You can see something over on the right below the left hemidiaphragm. I don't know exactly what that is, but it definitely is bright white and man-made looking. I don't know, maybe if that's another cardiac monitor lead, maybe. So this is what I'm talking about when we talk about the hardware, and you can see how bright white that looks. Okay, so what do you think this is? Now, as you look through your lung fields, you can see it looks like little cannonballs, especially on that right side. And you see some on the left as well, but they're pretty significant on that right side. This is multiple masses. This is a metastatic lung cancer. Okay. You're looking at this and you're thinking, my goodness, it almost looks like somebody's wedding veil is shoved in to this patient's lungs. Okay. This is pulmonary fibrosis. Okay. It kind of looks see-through, but there's something going on. Looks like things are just kind of stacked. Okay. All right. If you look at this, and I guess you have to be a lover of abstract art. Sometimes they'll talk about, this is CHF, and they'll talk about CHF, and they'll say that it looks like bat wings. Okay. You know, and you can see that fluid is going right through all your lung tissue from the heart all the way laterally. Okay, it's fluid in the lungs. All right, what do you see here? What I see here is a lawsuit. Okay, you need to make sure if you're x-raying your patients that you're doing pregnancy tests. Okay, if they are not sure, get a quick urine dip. Okay, you do not want to x-ray fetuses, especially late in the game, okay? Early or late, period. So you want to make sure your patients of childbearing years are not pregnant. Okay, this is like a kind of a ha-ha. This is actually a pelvic x-ray, abdominal x-ray, but you can see the fetus, the head, baby's head down. You can see the little ribs, arms and legs, the spine. You really don't want to ever have one of these come across your desk with your name that you ordered it. So just to keep that in mind. Now, obviously, if you have a mother, and it is kind of controversial, they'll talk about x-rays, and they'll, you know, if it's a hand, they can double shield them and different things. So they have to think about the risks versus benefits. So if it's something that doesn't have to be done today, that can wait until after the baby is born, then that's what you do. You wouldn't be doing chest x-rays unless you have to, obviously. All right, what do you think about this one? So you go through, you're looking at your lung fields, you go back and forth, back and forth, back and forth. What do you see? What don't you see? Okay. And I want you to look at the trachea. The trachea is displaced. And if you look at the left side of the lungs versus the right, you're going to notice on the right side there are no lung markings. Okay, this is a right pneumothorax. Okay, this is another pneumothorax, and you can see that mediastinal shift towards the right. Okay. All right. What do you think about this patient? This patient, did the tech forget to take off the underwire bra? No. This patient has free air. All right, what about this patient? First thing, we're going to look at the shape of the lungs. And they look almost square. Okay. This is a patient with COPD emphysema. All right. So just a couple little other pearls. What do you think the radiation exposure is when you order a CT pulmonary angiogram on your patients? Is it higher than a chest x-ray? Is it less? What do you think? Well, it's equals about 300 chest x-rays. So the moral of the story is you want to order a CT pulmonary angiogram when you are suspect of a pulmonary embolism. So you need to know the Wells criteria. And this comes into play a lot. It says, you know, I think that there's a lot of things that you have to be aware of when you work in ER urgent care, but you also need to know when to send your patients from primary care and from the community to the emergency room. So it's important that you know your predictors for Wells criteria. So the other thing I want you to look at for those of you that are prepping, I know that there can be a multiple select. There were some students having a big debate over a multiple select question that recently was, I don't know, it was on one of the study groups, but anyways, they were talking about, you know, it was select the most common signs or symptoms of pulmonary embolism. And it was funny because they used the Wells criteria, and if you knew the Wells criteria, you were going to get it right. So, you know, I think one of the questions was the clinical signs of a DVT, and I think they had tachycardia And I think maybe they had, I'm not sure what it was, so maybe shortness of breath, and then there was hemoptysis, and it was like all of them could have been the right answer, but they wanted you to pick the 3 most common. So if you look at the clinical feature and the points, you can see the hemoptysis is way down on the list. So it can happen, but it isn't as common as somebody who has tachycardia, okay, and or somebody who has clinical signs of a DVT. So you're going to look at these things. Does your patient have clinical signs and symptoms of a DVT? And we're going to go, there's Wells criteria for DVT, and we're going to go through that in just one second. Is the pulmonary embolism the most likely diagnosis? It's kind of like a loaded question, so you need to know about that. So does your patient have a history of a previous PE? Okay. Do they have a known clotting disorder like factor V? Do they have a known cancer? Are they on a hormone, especially, somebody who's had recent initiation of an estrogen-containing drug, birth control pills, estrogen supplement? Is the patient pregnant or in a postpartum state? Have they had a recent trauma or surgical procedure? Okay, these are all patients that you worry about pulmonary embolism. They have a big red flag. They should be in your differential. Okay, tachycardia greater than 100 beats per minute. Consistently, we see that with our patients. You may see them, hypoxic as well. Talked about the immobilization or surgery in the last 4 weeks, previous diagnosis of a PE, your hemoptysis, active malignancy. Okay, so if you add these things up, if they have a moderate to 2 to 6 is moderate probability, greater than 6 is a high probability, you're going to want to get that CT chest angio. Okay, moving on to the Wells criteria for DVT prediction, they kind of go hand in hand. Does the patient have an active cancer or treatment within 6 months, or are they in palliative care? Do they have paralysis, paresis, or immobilization of a lower extremity? Have they been bedridden for more than 3 days because of a surgery? Do they have localized tenderness along the distribution of the veins? Is the entire leg swollen? Is there unilateral calf swelling greater than 3 centimeters below the tibial tuberosity? Do they have unilateral pitting edema? Do they have collateral superficial veins? Is there an alternate diagnosis that's more likely or more likely than a DVT? So you figure these out. So these are 2 things you want to, you have a good handle on your Wells criteria. It's just one of the ways you can screen in your head and be able to make a decision whether or not, does the patient have a PE or not? Are you going to do a pulmonary angiogram or not? So I'm going to leave you with one last chest x-ray. I'm going to have you take a look at this person, take a look. What do you see? I know it's a little bit hard watching these on the video versus a real life chest x-ray in front of you, but take a look. Are they rotated? Do you see any infiltrates? Do you definitely see some hardware? So this is another haha. If you look at this patient, this is a vet who had lost his right arm and shoulder due to a trauma. Okay. So this is one of those. Make sure you look for the forest through the trees. I wish you luck in your clinicals, your clinical practice, in your prepping. I hope this helped you. I know that chest x-rays gives advanced practice nurses and nurses in general a kind of a hard time. So I hope this helps. Again, if you like this, you like what you saw, keep coming back. We're going to have some more. My intent is to continue on and do some more of these harder topics and think of innovative ways that nurses can learn. So I hope you enjoyed this, and best of luck to you.